I'd like to start on the note of breast cancer. When I went for my breast cancer screening earlier this year, I went and they said, we have an AI-enhanced breast cancer screening you can have. And I went, terrific. But I had to pay for it.
Yeah.
And as I started looking around and asking, why is that? We've had hundreds of AI-enhanced radiology things approved by FDA, but there's no billing code for them, not just in breast cancer, but also in prostate cancer screening, which you should also schedule as well. It's not just breast cancer you should be thinking about. Mm-hmm. What does that mean for where we are right now, where it seems like we have so much hope, and yet the payers are saying, we're not sure yet that this really is worth it and this really is going to be valuable?
It's a great question, Bertha. And I think what you highlight is the disconnect between the level of evidence for a regulatory decision and the evidence needed for a payment decision or a coverage decision, right? And I think on the latter group, and I'm not in the payer space, sort of it gets to what's the outcome basis for this technology? What's the incremental benefit and outcomes to patients to justify the additional cost? So I think that's something that payers are still thinking through, trying to navigate around. And I think that's why that cost was passed on to you and not folded into your benefits design.
So as you think about innovation, you're the head of innovation at MSK, looking at these AI tools. How do you think about what really is going to add value and what is just, okay, let's use the tools and make it more interesting?
Great question. I think artificial intelligence really will be disseminated across all of healthcare. So I think different health systems may perceive or index on a particular value proposition based on what their needs are. I think for us at Sloan Kettering, the three big buckets that we're thinking about being very thoughtful about baking in AI into our ecosystem is our research journey, patient experience, and leveraging AI thoughtfully to optimize care decisions. So I think those are the three main aspects that we're circling around, at least for the near term.
So when you say care decisions, what does that mean? Is that using it as a diagnostic tool, or is that just making it easier for doctors to file their electronic health records and follow up, their staff to follow up with patients?
So plausibly all of the above, actually. I think maybe it would be helpful to tell a story. So a patient, it's Breast Cancer Awareness Month. Maybe a lady goes in for her mammogram, and let's say she happens to have dense breast tissue. So then, through the lens of enhancing care decisions, the AI algorithm could appropriately flag on the mammogram areas of concern that may be missed by a busy clinician. So the algorithm could surface a speculated lesion in the right breast that maybe he or she, the radiologist, could spend extra attention to. It could also help decisions by if a patient has a biopsy, same patient has a biopsy and it shows cancer, unfortunately, then the AI algorithm could now recommend available therapy, experimental therapy for that patient's journey. So there are many ways that AI could play out, but just using this one story, you could see how easily it enhances the quality of decision-making with respect to that patient in particular.
I mean, that's sort of my story, why I wanted the AI enhanced. But I wonder, do we know how often it comes up with false positives versus false negatives?
So I can't answer that question in a general sense, but I think the key thing, and you actually prompted me to call this out, is regardless of how AI is deployed, it's very important to have a human doctor in the loop, right? So sort of the decision-making is assisted by AI, not directed by AI. So if you have this framework, then it does mitigate or dampen the impact, negative impact of a false positive or even a false negative. So I think a human in a loop idea is something that we at Sloan Kettering certainly double down on as we sort of deploy these algorithms across our entire universe.
The other thing I wonder about is as this plays out, we hear it not just in healthcare, but in discussions of AI in general. Mm-hmm. We've had artificial intelligence for a couple of decades now, large language models for a long time.
Yeah.
A lot of folks have been looking at that to be able to comb through records and be able to find information and detect patterns. In healthcare, from your vantage point, how is this moment different from what we've already been using?
So I think the big distinction between now versus, say, 7 years ago is, one, the compute power is just significantly much more advanced. So the ability of these GPUs, which is distinct from CPUs in the prior rendition, does process information quicker and better. The storage abilities is also much more increased now with the cloud and everything else. So I think it's a function of storage, impute, which leads to inference, most importantly, capital. I think now we're certainly in an AI investment boom, and there's a lot of capital flowing into this sector in particular. So I think those three things really make this moment feel like there's a step change sort of coming with respect to the ability of these things to instantiate real improvements in sort of all of our lives, certainly in healthcare.
The capital seems to be happening at centers of excellence like MSK or Mayo or Cleveland Clinic or the big academic medical centers.
Yeah.
But are other hospitals being left behind because they're really grappling with very, very slim margins?
That is true, and I think certainly for Sloan Kettering, we are very thoughtful, given the position we occupy in the oncology ecosystem, to the extent possible, democratizing insights we get from AI, whether it's through partnerships or publications. There's a responsibility that I believe Mayo Cleveland Clinic share, given that we are elite institutions in healthcare. And part of our mission is to broaden, disseminate our services, our insights to sort of intensify the impact we create. So I'm not answering your question directly, but I will say that this is a capital-intensive game, yes. It does involve partnerships with strategic entities like the companies you would expect to be in the space. And not every health system has access to that kind of relationship. So I think it's incumbent on all of us sort of occupy this earned but elite status to really democratize to the availability and benefit of all patients, all cancer patients, the insights we generate. So yes.
You are launching programs at MSK.
Yeah.
Talk about one of the programs that you're really excited about where you are using AI and where you think you really can make a difference and maybe help even the playing field.
So one program that we're really, well, there's several, but one that comes to mind is an initiative that we've just launched and we're now scaling that gets about how can we use AI thoughtfully to optimize the whole clinical trials journey for our patients. So decentralized trials with the pandemic has really taken off. Less so in oncology, candidly. So now what we're thinking about, and we have an ecosystem that we've built out to sort of house this, how can we think about AI on the patient registration, on the consent, on the adverse event reporting, on the data feeds from the medical record to the data capture on the sponsor side? How can we automate the entire patient journey, ideally, even up to enrolling patients in their house in a decentralized format? That's something that we're really excited about, I'll say bullish on moving forward at Sloan Kettering. It will take time, certainly like years, not months, but it's a journey that we're well underway. And I do think that in oncology, unlike most other chronic conditions, a clinical trial for some patients, people with rare diseases, recurrent diseases, or just difficult diseases that have no available line of therapy, a clinical trial is actually care for those patients. So the ability for us to scale the clinical trials infrastructure to get to as many patients as possible, so democratize access, we're really, really excited about that.
So hopefully you don't have to be near, Mass General Hospital,
correct.
Columbia University, or MSK, and you could be in rural Oklahoma.
Potentially, right?
Maybe be part of a trial.
So could clinical trials decentralization solve that last mile problem?